Hi everyone, welcome back to my YouTube channel, and today we are going to talk about age-related changes in oral mucosa. So let's start our topic with introduction. Oral mucosa lines the oral cavity and serve as a protective barrier against mechanical trauma, pathogens and chemical irritants. It also plays important role in sensation, lubrication, immunity and speech. With advancing age, the oral mucosa undergoes structural, functional and physiological changes influenced by intrinsic aging, systemic conditions, reduced immune response, and environmental factors such as medication, smoking, and oral hygiene habits. Understanding these changes is important for geriatric dentistry, diagnosis, and treatment planning. Structure of oral mucosa. Major components include epithelium, lamina propria, submucosa, and underlying structure. Epithelium is stratified squamous epithelium that may be keratinized or non-keratinized epithelium. Lamina propria is a connective tissue layer with collagen fibers, blood vessels, and immune cells. Submucosa contain glands, fat, and connective tissue in certain region. Underlying structures include bone or muscle depending on the site. Types of oral mucosa. It has three types: masticatory mucosa, lining mucosa, and specialized mucosa. Masticatory mucosa is keratinized. It is present in gingiva and hard palate region. Lining mucosa is non-keratinized and it is present in cheeks, lips, floor of mouth, and soft palate. Specialized mucosa is present at the dorsum of the tongue. Age-related changes. Oral mucosa exhibit various degenerative and structural modification due to aging, which may alter its texture, color, thickening, and functional performance. They include changes in the epithelium, connective tissue changes, vascular changes, salivary gland and mucosal moisture changes, sensory and neurological changes, immune and inflammatory changes, and changes in tongue and specialized mucosa. First are changes in epithelium. They include thinning of epithelium, reduced keratinization, and flattening of epithelial ridges. Number 1. Thinning of epithelium. Epithelial layers become thinner due to reduced cell proliferation. It results in increased transparency and vulnerability to trauma. Second is reduced keratinization. Keratin layer become thinner in keratinized mucosa with age. It makes gingiva and palate more susceptible to irritation and inflammation. Third is flattening of epithelial ridges. That is, reed peaks become shorter and less pronounced with age. It reduces adhesion between epithelium and connective tissue, increasing the risk of mucosal tear. Second age-related change is connective tissue changes that include reduced cellular count, increased fibrosis, and reduced ground substance. First, reduced cellular content. Fibroblasts decrease in number and activity. It leads to slower healing and reduced collagen turnover. Second is increased fibrosis, that is, collagen fiber become thicker, more cross-linked, and less flexible. It makes mucosa tougher but less elastic. Third is reduced ground substance. It is decreased hyaluronic acid and proteoglycan that result in reduced tissue hydration. Oral mucosa become dry and less resilient. Third age-related change is vascular changes that include decreased vascularity and fragile capillaries. Decreased vascularity. A fever and narrow blood vessels are there that reduce tissue perfusion. It causes paler mucosa and delayed wound healing. Second is fragile capillaries. These are vessel walls that may weaken, increasing susceptibility to petechiae or bleeding under pressure. Fourth age-related changes in oral mucosa is salivary gland and mucosal moisture changes. It includes reduced salivary flow and altered saliva composition. First, reduced salivary flow, that is also called as xerostomia. It is common due to aging, polypharmacy that may include antihypertensive and antidepressants, and systemic diseases. It results in dry mouth, difficulty swallowing, increased risk, carries risk, and mucosal soreness. Second age-related change is altered saliva composition. It results in reduction salivary protein and enzymes and buffering capacity. It affects lubrication, taste, and antimicrobial defense. Fifth age-related change is sensory and neurological changes. It includes reduced taste perception, diminished sensory nerve endings, and burning mouth sensation. Reduced taste perception include loss of taste buds on tongue papillae with age and decreased taste sensitivity, especially to sweet and salty stimuli. Second is diminished sensory nerve ending. It reduced tactile and pain sensitivity. Injuries may go unnoticed, increasing risk of trauma or infections. Third is burning mouth sensation. It is more common in older adults, sometimes linked to neuropathic changes or xerostomia. Sixth age-related change is immune and inflammatory changes. It include decreased immune cell activity and increased susceptibility to infection. First, decreased immune cell activity. Langerhans cells, macrophages, and lymphocytes decrease in number that reduce mucosal immune defenses. Second, increased susceptibility to infection. Greater risk of fungal infection, especially oral candidiasis, is there, and also slow inflammatory response that compromises healing. Seventh age-related change is changes in tongue and specialized mucosa. It includes atrophy of papilla, fissured tongue, and decreased taste bud density. First is atrophy of papilla. Filiform and fungiform papilla reduce in size that give a tongue smoother appearance. Second is fissured tongue, that is shallow or deep fissures become more common with aging tongue. Third is decreased taste bud density. It results in decreased taste acuity. Clinical implication of age changes in oral mucosa. It includes increased injury and ulceration risk as it becomes thin, less elastic mucosa, so it tears easily. Denture wearers are more prone to traumatic ulcer. Second clinical implication is reduced healing capacity as slower epithelial turnover and poor vascular supply delay wound repair. Post-surgical outcomes may require longer recovery. Third clinical implication is higher incidence of mucosal lesion, as conditions such as candidiasis, lichen planus, angular cheilitis, and leukoplakia become more common. Dryness increases susceptibility to fissure and infection. Third clinical implication is ill-fitting dentures, as reduced ridge height and changes in mucosal resilience affect denture retention. Older mucosa tolerates pressure poorly, causing soreness. Fifth clinical implication is increased sensitivity to medication and irritants. It includes fragile mucosa that reacts more strongly to spicy food, chemicals, and alcohol-based mouthwashes. Summary: thinning of endoepithelium and reduction in keratinization is there with aging mucosa. There is increased collagen cross-linking and fibrotic changes. There is reduced vascularity and slower healing. There is low salivary secretion leading to dryness of the mouth. There is decreased taste sensation and reduced nerve supply. There is high risk of trauma, infection, and mucosal discomfort. Conclusion of this lecture video. Aging results in significant structural and functional changes in the oral mucosa. These include epithelial thinning, reduced keratinization, decreased vascularity, increased fibrosis or reduced salivary flow, and diminished sensory perception. These alterations compromise the mucosa ability to resist trauma, heal wounds, and maintain oral homeostasis. Understanding these changes is crucial for effective geriatric dental care, early detection of oral diseases, and appropriate management of mucosal conditions in older individuals. And this was all about age changes in oral mucosa. Hopefully you liked the video. If you do, don't forget to like, share, subscribe, and comment. Thank you for watching.